All right. So help us understand what you learned in those early years and what you continue to evolve or allow to evolve in terms of your understanding of what's the proposal that this needle is doing and what is it mainly meant or intended to serve in terms of its effectiveness on causing some relief of pain or.
Yeah, so myofascial pain and dysfunction is not a common concept that's taught in entry-level physical therapy programs. So muscle, one of the largest organs in the body, is kind of dismissed in physical therapy programs other than exercise and movement. However, there are many articles, thousands, hundreds of thousands of articles about muscle pain and myofascial trigger points and myofascial pain syndrome, which are caused by trigger points. So that's out there. It's been established in the worldwide literature for many, many years. So trigger points are a possible source of the patient's symptoms, whether they're active or latent trigger points. They can also be a contributing factor to the patient's symptoms or their presentation. So you have to be skilled manual therapists. You have to have great palpation techniques. You have to be able to identify a taut band within a muscle, a skeletal muscle, and identify a hyperirritable spot within the taut band in the muscle, and whether that produces a familiar report of pain that the patient has come in to see you for, which would be an active trigger point. And a latent trigger point would be when you press on that irritable spot in the muscle and it's an unfamiliar pain that the patient experiences. There are taut bands that aren't trigger points. And so just because there's a taut band doesn't mean it's a trigger point. You have to have the criteria, and the criteria has been established and reestablished in 2019 with a Delphi study by Cesar Fernandez de la Peñas and Jan Damerholt in 2019, where they did a Delphi study across the world and came up with the criteria that's consistent to identify myofascial pain, especially trigger points.
Okay. All right. So those that are a ropey band, something that's taut, but it's not by definition a trigger point, might be something that we feel underneath our finger for those of us that are clinicians, palpatory, ropey band. But what are the criteria? That they're not reproducing the familiar pain?
So the criteria is a palpable taut band, and it has to have a hyperirritable spot within the taut band. So it has to produce pain when it's palpated, whether it's through cross-fiber flat palpation or pincer palpation. And if it reproduces the patient's report of symptoms or any symptoms they present with, then that would be an active trigger point. If when you press on that taut band in the hyperirritable spot within that taut band, it's an unfamiliar report of pain, whether it's local or referred pain, that would be considered a latent trigger point. And the research out there would describe latent trigger points have more of an influence on motor movement patterns and motor movement coordination and muscle activation patterns.
Okay. So it takes away the responsibility of the clinician to determine, based on their palpatory skills, more it's indicated by the patient saying, "Ow, that's my pain."
Yes. Yeah. So
okay.
That would be an active trigger point. But when you're palpating a muscle, for example, if you were palpating the infraspinatus, somebody who's in your clinic for shoulder dysfunction, and you're thinking maybe rotator cuff, and some of your specific rotator cuff special tests are coming out negative, and you go ahead and muscle. So perhaps the infraspinatus person has anterior shoulder pain. So I palpate the infraspinatus and I get on the top band in a hyperirritable spot. If it reproduces their anterior shoulder pain, then that more likely is an active trigger point and would respond very well to a dry needling technique.
Okay. So the concerns about the unreliability of from clinician to clinician, or even within intra-tester on palpatory skills, all of those studies that have shown that we're not really great at one person compared to another, or one person compared to themselves on a palpatory finding type of studies, that doesn't create much of a concern when you're dealing with this.
No, because there's many studies that have shown that if a clinician is educated in the specific palpation techniques to identify trigger points, there is significant interrater reliability. And my Bergen colleagues have pointed that out and published in the research out there. And then, what's his name? Dutch therapist, Karl Braun, did a couple studies on shoulder pain, shoulder dysfunction, where they compared interrater reliability between clinicians and patients with shoulder pain, and had moderate interrater reliability as well. So if you're trained in the technique, there is much more substantial interrater reliability versus if you're not trained in how to palpate muscle,
Mm.
specifically for the
Mm.
presence of trigger points.
Okay, so in addition to what a person might get in entry-level physical therapy education.
Correct.
I see.
Correct. Right.
Okay.
So if you think about entry-level education, how typically muscle is taught to palpate, you do pulsing contractions and you palpate along the muscle and you palpate the origin, you palpate the insertion, but very few are spending the time to teach students specifically where the motor end plate exists in a muscle and how you would go about palpating specifically for the diagnosis of, for the presence or absence of trigger points within that skeletal muscle. It's just a different type of palpation. And we use cross fiber flat palpation when we have a bony backdrop or a hard surface to palpate against. And when we have fusiform muscles like the biceps or gastrocnemius, we use pincer palpation where we get more of a three-dimensional palpation of the entire muscle belly.
Okay.
So it just has a specificity of the technique to identify or for the diagnosis of the presence or absence of trigger points.
Mm-hmm. Mm-hmm. Yes. All right. So a trigger point, once it's been established that yes, this is an active, let's just say active trigger point, what is the needle doing and what does it propose? How is that going to correct someone? So if I have the inability to raise my arm without pain, I do have some loss of motion in that it's in my upper trapezius down to my shoulder, a common presentation that a lot of listeners out there might see patients with most every week. And we decide, okay, there's an active trigger point in the upper trapezius, the supraspinatus area, and we decide to dry needle. So of course, someone's obviously been trained to do that. So they decided to dry needle. What's the penetration and the insertion of that needle doing to that trigger point?
Yeah,
And really,
so
ultimately, I guess,
yeah.
ultimately to correct that patient's really primary complaint.
So the key is, A, does it fit into the clinical reasoning process as either a contributing factor or a source of symptoms? Then we have to include our knowledge and abilities in the pain sciences. So is this a peripheral, something that has peripheral sensitization, or is this central sensitization, or is this truly a peripheral nociceptive issue where the issue's in the tissue and the tissue is the trigger point? So if it is, then we got to find the key to the patient's report of symptoms and find that key trigger point in that, let's say, upper trapezius, as you pointed out. What I would have to know first is, what is the common referral pattern for the upper trapezius, which is up to the head. And there's a couple areas of the trapezius that refer to the superior anterior aspect of the shoulder. So I'm not going to needle the upper trapezius if I don't think it's contributing to the patient's shoulder. I'm going to try and find the muscle or muscles that are contributing to the patient's presentation through my clinical reasoning process, right? Mm-hmm. So then if I confirm that it's a peripheral nociceptive issue, meaning that the issue is in that muscle tissue, then I'm going to insert the dry needle into the trigger point, and I'm going to look for a twitch response, a latent twitch response for effectiveness of the dry needling treatment. What that is doing is stimulating an action potential across the sarcomere where the trigger points are located. And pretty much the trigger point is a contracture of sarcomeres. And for some reason, after the muscle contracts, it stays in that contracted state because of the excessive amount of acetylcholine in the area and the decrease in acetylcholine esterase to break up the acetylcholine. So you get a contracture of the sarcomere. So the needle is a precision instrument that is able to go intracellular into that trigger point, create the action potential, and deactivate that trigger point. And that, of course, has to be followed up with manual therapy, neuromuscular education, and therapeutic exercise. So you might be using, as people refer to it, a passive modality, but you're not going to use that modality without some active treatment, whether it's joint manipulation with it or soft tissue mobilization, but specifically some type of neuromuscular re-education to reactivate, retrain the brain, retrain the movement system to activate those muscle fibers that have been in a contractured state for who knows how long. You know, it could be a week, could be a day, could be a month, could be years. But what we do know is that trigger points can remain in muscles for a long period of time if they're not addressed, just from overload.
Sure. Hear the entire episode for free on iTunes, Spotify, other favorite podcast players, or go to mechanicalcareforum.com.